Gazella.
Good morning,
Just be
everyone.
ready on the podium.
Yeah, please proceed.
It's not moving. So these are the abbreviations which I'll be using today. We all know that CCT, higher the CCT, there is overestimation of IOP, and the lower the CCT, there is underestimation of IOP. So why is CCT important? For accurate IOP measurement, to risk stratify the patients, for clinical decision making, and to prevent misdiagnosis or inappropriate treatment. It has a role in NTG and OHT, and even for patients who are undergoing refractive surgery, to either classify them as OHT or glaucoma suspects. But the lacunae in literature is that ultrasonic pachymetry has a disadvantage of being a contact technique, and there have been multiple studies comparing ultrasonic and non-contact, as seen here. Most of them have been done on healthy eyes, except for one study which did on glaucoma patients, just like in our study. And all of them have contradicting results, which some showing ultrasonic showing lesser CCT, some showing non-contact showing lower, some show no difference, and some show that both are highly reproducible. Some show that the non-contact is more consistent. So that's why we decided to compare the repeatability of CCT taken by non-contact specular microscope and to assess its agreement with ultrasonic pachymeter in glaucoma patients. It's a cross-sectional analytical study conducted at RML Hospital. So this is the inclusion criteria of OHT, POAG, PACG, and controls according to the standard definitions. Exclusion criteria was diseased corneas like edema, infections, opacities, or any curvature abnormalities, dystrophies, severe dry eye, contact lens wearers, history of previous ocular surgery, or those not giving consent. In the methodology, after we did a preliminary examination and divided the patients, a CCT was taken by 2 observers, and the non-contact 3 readings were taken, and an average was taken of these 3, and ultrasonic 5 readings, and the lowest and highest were excluded, and the average of the middle 3 were taken, and the readings were taken between 9 a.m. to 4 p.m., 3 hours after awakening, and within 1 hour of each other. So we used descriptive statistics, Bland-Allman plots, and intra-class correlation coefficient and Cronbach's alpha test to see the magnitude of correlation. So here, as we can see, the average CCT is showing consistently lower in the non-contact specular microscope. And for inter-observer variation, for both observer 1 and observer 2, all the levels are quite high in both Cronbach alpha and ICC. And even for intra-observer variation, for the total data, also showing all higher values, and even after dividing them into groups also. So in the Bland-Allman plots, this is of the whole data. It's showing that most of the data is nearby to the mean, and within the limits of agreement with very few outliers. And for POAG, you can see here the chart is very similar in both the eyes, as well as PACG, showing high correlation, and even for OHT, and even for controls, all being nearby to the mean and with the limits of agreement. So the strengths of our study is the first study to compare CCT and POAG, PACG, OHT with control eyes in Indian population, and is the first study to use more than one observer with multiple readings for ultrasonic and non-contact. But the limitations are that it is limited to those more than 40 years with healthy corneas, and it cannot be generalized to other ethnic groups. So we can conclude that CCT measurements on glaucomatous eyes with ultrasonic pachymeter were significantly thicker than with non-contact specular microscope. Although the non-contact specular microscope can measure CCT with excellent repeatability and reproducibility, it can be used interchangeably with ultrasonic. And in the future, studies can be conducted with larger sample size, wider inclusion criteria, wider age range, and can include other instruments also for checking CCT. These are the references. Thank you.
One question, please. You can start. One question. Anybody wants to ask one?
You said the Bland-Allman graph shows good agreement, but in the end said they are not interchangeable. If you think it's a very good agreement, then why should it not be interchangeable?
Intra-observer variation. So that Bland-Allman was showing how much observer 1 and observer 2 were agreeing with each other.
I'm talking about regarding the interchangeability of the readings of ultrasonic and the non-contact this thing CCT measurements. You said it cannot be used interchangeably.
Because
If
there was
if
a
the
sig-
agreement between these two are good, then why can't it be used interchangeably?
That graph was showing for ultrasonic and for non-contact, but it was showing consistently lower for the non-contact, sir.